No disclosures whatsoever. I don't think Steve actually does, as far as
Nothing
relevant to this talk, at least. So for our practice, we first started considering switch to a DAA back in 2017. The major reason for it was a lot of patient interest. Even back then, a lot of, as been outlined before, a lot of literature and kind of advertising on the internet, especially through the United States, about the joys and wonders of the DA approach. I must say, at that point, I was a major skeptic, and but you hear enough people coming in and asking about it, it kind of perks your interest a bit. So that was probably a major driver. So we ended up looking at the evidence, and as outlined already, it's a bit conflicting as far as, you know, ups and downs of that. Won't belabor that. And another factor was we had a colleague that was also local down on the highway a little bit, instituted a program in Penticton, and was having great success with implementing his program, and we felt that, you know, it was a good opportunity to get on his momentum to a large extent. The other aspects that we thought was, you know, very useful in our situation was the potential for an ERAS program as far as getting people out of hospital quickly. All right. The host has stopped our video. Is it over here? What's going on here?
Can you guys see Ross and Steve? They're presenting off of mine, and I can't. My video's not allowing me to start.
All right, all good.
Okay, he'll just keep.
We can see the slides, guys. We can't see your faces.
All right,
I'll put your video on.
That makes you fortunate.
Yeah, you're lucky. You're lucky.
I don't know,
Put your
Ross.
video on.
You have such a wonderful, wonderful face there. I think we need to somehow see it.
Oh yeah, there we go. Hey.
There we go.
There we go.
All right, there we go. So we want to go back a slide, I think. All right, so yeah, the ERAS stuff, and as far as the early recovery from anesthesia, same day discharge, not requiring that same bed utilization, and getting throughput based on not requiring that, was a huge motivating factor. And personally, I thought the X-ray integration, like Raj had already brought up, and that ability to really dial in and ensure your offset, the leg length, cup positioning, all that is as accurate as you can keep it. And since both of us were relatively early in our careers, hadn't been too set in our ways, we felt that changing up the practice wasn't so onerous. We were into totally dinosaurs, as it were, from Lisa's talk. So how we went about doing it. So there was, I said before, Dr. Bell down in Penticton had already got a program up and running in Penticton. And he had brought in, I think, Dr. Sharma to talk to our hospital administration and health authority about getting the program started and giving the various benefits of getting that going. So we were fortunate enough to piggyback on that momentum. So they ended up getting a donor for the hospital from the hospital foundation that was able to purchase a HANA table to get the program running. And based on conversations with other people starting this up, we felt that would be the best in our hands as far as instituting a program here rather than doing it with a standard operating table. So both of us ended up going to the cadaver course and getting familiar with the approach on people we couldn't hurt, and going through a couple of dissections with that. And I had the opportunity to do a visiting day with Dr. Sharma in Calgary, seeing how his program was running. And Dr. Sylvester ended up going out to Ontario and having a similar experience with a surgeon in Mississauga.
It's actually Toronto.
In Toronto? You got it wrong?
Yeah.
It was Toronto. Okay, there we go. So when we started to get going on this, Dr. Sharma was kind enough to come out here and get us the program up and running. So he assisted us with the first 8 cases over 2 days, 4 apiece. And then Steve and I went on, basically assisted each other for the first 10 cases of the piece to kind of double up our learning curve. You can see what the other surgeon was doing and get extra experience that way. Well, I think Raj had a slide that kind of brought this up, but as far as our patient selection for the first 30 to 40 cases was very conservative as far as patient body habit is, various anatomical reference points, and we were just, tiptoed through the learning curve as safely as we could. And as far as that aspect of it, certainly, Elisa brought this up as far as the learning curve and the patient risk factor associated with it. During the initial consultations for people going through this, I certainly laid that out for them in entirety, just to be sure that they were aware that if they were choosing to go ahead with this particular approach, that this was early on in our experience here, and therefore there was likely going to be an increased risk of complications. So, which I thought was entirely appropriate, just that they knew what was actually going on. So as we became more comfortable with it, we started expanding our kind of indications, as you expect, larger patients with body habituses that are more kind of average, we'll say, distorted anatomy, elderly patients, failed hip fractures with DHSs and the cannulated screws, some basic metastases and fracture care. So I think as we became more kind of comfortable with the approach and the outcomes, being enthusiastic about what we were seeing, we started broadening who we were using this approach for. So our current situation here, we have 3 surgeons doing DA hip replacements in Kelowna now, Steve, myself, and Dr. Kurtz. We all use the hand table for it, so none of us are using just a standard operating table at this point. We had as it was successful in the enthusiasm for it locally, we had a second donor willing to purchase a DA table for the hospital. So currently, from my perspective, pretty much the majority of my primary surgeries are done through a DA approach, simple revisions as far as a component exchange and various short stem femoral exchanges. Acetabular revisions we're starting to think about doing. I don't know if we've gotten doing that too vigorously yet. Occasional bipolar, depending on surgical assists. As far as the stability assessment, I think I'm the only one still doing this these days. But as far as taking the boot out of the spar and doing a traditional dynamic test, it makes me feel better. I don't think it's actually necessary. I think it's more for me than anything else, but it makes me sleep at night. So there we go. Yeah, so I think how it went. So initially, it certainly expanded our operating time. We were around 1 hour and a half to 2 hours, depending on the case. Within the first 30 to 50 cases, that dropped quite reliably to around an hour, give or take. So by about 6 months in, we'd returned to our previous caseload, doing four primary joints a day. And that's continuing. We did 4 today, actually. So it's been, and I said average times, I would say somewhere between 50 to 70 minutes, depending on patient factors. Go for it.
All right. Okay, we'll switch over to me. So in terms of the learning curve and how this actually felt to do, I'd say the first 6 months were considerably more stressful than what we'd experienced previously when doing our surgeries. Now, I was maybe a little bit more uncomfortable with, or more comfortable with changing, because I'd recently changed from primarily lateral to drifting more towards doing a posterior approach. So things were already a little unsettled for me, but both of us definitely found ourselves thinking a little bit more the night before about what we were going to be doing, and sweating considerably more. And that wasn't just the lead, which incidentally did get completely saturated on at least one occasion. This femoral exposure tended to be the most difficult thing initially, which I don't think is a surprise to anybody who's tried this or anybody who's read about doing it. And there's also some challenges with the staff not being familiar with the techniques that we're using, with the equipment that we're using, even running the table, getting the appropriate x-rays and so on. After about 6 to 12 months, as Ross was alluding to, we're getting quite a bit more confident. The exposures were less difficult. Everything just started to click. and to run a lot more smoothly. And the OR times, as he said, dropped considerably, which meant less time pressure on the day to get your cases done, less stress, and just a generally speaking more tolerable experience for everybody involved. And since then, as he sort of indicated already, we've been just sort of expanding our indications and really refining the techniques, little tricks and tips that we pick up and pass on to each other and from others as well that really do make things quite a lot easier, which is of course the case with all approaches. This is just a little graph that we cooked up to show kind of a visual representation of how our case volumes actually increased. Now keep in mind that we were very conservative initially with our patient selection, and also keep in mind that COVID has played havoc with our access to the OR. So it's difficult to really give an accurate representation of how things went, but basically this is combined numbers for us. We started late in 2018, so the numbers there are quite low. And then I would say in 2019, we still weren't doing as many people as we normally would, but even with significant OR reductions in 2020 and 2021, the number of people that we're doing via DA has really increased, and that's reflected in these numbers. And it definitely has become the primary approach both of us use for, I would say, 75 to 80% of our primary hip patients. We did have some complications, and it's important to discuss those because everybody's going to want to know about those. We had 2 dislocations, one each early on in our practices, one at 6 weeks and one immediately post-operatively, and both were revised and did well after that. There were femoral cracks, 4 of them, one of which was trivial and we did not repair. We had a Karai stem in that person and they did extremely well with no problems. The others were wired and that was not particularly difficult. I did notice a question there asking about access for wiring. Without going into the details of it, it's really not a problem at all. We've had a few infections, but certainly no more than we would expect for similar numbers. We're at about 600 in total between the 2 of us at this point. A couple of wound breakdowns with OR debridements. We didn't have any of the much discussed trochanteric fractures, although I did manage once to put a Holman directly into somebody's trochanter, but that didn't actually cause a fracture, fortunately. We had no femoral perforations, which might be due to the stems that we used. We generally use either a Karai or an Actis stem, which have a very blunt tip on the broach, and that just really doesn't lend itself to easy femoral penetration, in our opinion. We had no major nerve palsies, femoral or otherwise. There are LFCN palsies, and pretty much everybody has some degree of that, and pretty much everybody gets better, and pretty much nobody cares one way or the other at the end of it. Once they've recovered, they're quite happy with their hip. We've never had any knee or ankle fractures or any other fractures, which I know have been reported in the literature, and we had 1 transfusion that we can recall. Keeping in mind, we're not formally gathering data, but when you're trying a new approach, pretty much everything that goes wrong is essentially burned into your brain, so it's hard to forget most of these. In terms of what went right or what we like about this, we noted right from the start an excellent acetabular exposure, really very good. Femoral exposure at this point especially has really been adequate for everything that we have ever needed. We've cemented stems, we use cementless stems, we use relatively long stems like a Karai, we've used short stems like an Actis and others. We've been able to wire. We've done a couple of removals, stem removals, both of which were well ingrown, I might add. Without any difficulty in terms of access. And we've managed in a couple of cases when it's necessary, especially for a very tight canal, to get a long straight reamer down the femur, or at least I have, and that access wasn't difficult. I've never put in a really long revision stem through this approach, but based on my experience with that, I think it would be possible if you wanted to try it, provided you had the experience. We really like the X-ray. We like having the access to referencing component position, offset leg length. I know we've talked about that, but especially in cases of distorted anatomy, such as say a dysplastic hip or a deep protrusio, which we've done several of these. It's just really nice to know exactly where everything is, and at the end of the case, to be very satisfied that everything's as good as it can be, as Raj pointed out. It definitely helps with repairing fractures and yes, the complex cases, distorted anatomy. We've had very good success with the same-day discharge program, and this was an added wrinkle because we didn't have that either when we started this. So we kind of started both programs at the same time. But, you know, just going along pretty standard criteria for this, we've had a really good success. In fact, pretty much everybody that we earmark to go home does manage to. Occasionally they don't. That usually has to with not actually being able to get physio or somebody to see them and get them up, or because it takes too long for their spinal to come out. So those are usually the things that limit us. Occasionally, one of our anesthetists will prefer to give narcotics in their spinal, and then there will be lots of vomiting, and that might hold us up too. But overall, we've done very well with that, to the point where we're now considering and working on expanding that to a total knee program as well. And then just an anecdotal experience, this is not data, so take it with a large grain of salt, but our experience with the early outcomes for our patients have been excellent. You know, you have those occasional patients when you're doing a lateral or posterior who come back to see at 2 weeks, because that's usually when we see them the first time, and they're doing great. They're walking around, they don't have a cane, they don't have any pain, they're just delighted. That was occasionally before, now it's most of them. I would say that, you know, as I said here, the top 10% outcomes for the standard approaches is more or less the average of what we tend to see with an anterior. But that's, as I said, totally anecdotal. Sorry, we are in the hospital. Somebody's losing it on 4 East. Then we have where we're going next. So we are using an X-ray navigation system, or we're trialing it. We've not had much OR access to play with it, so it's a little early to make any conclusions. So far, it's been interesting, but it's not yet clear that we're going to continue to use it, or that it's hugely changing anything for us. We'd like to do some revision, more revisions through this approach, but we'll need to actually be able to travel easily to do that. So that hopefully will happen soon. You do need 2 assists, and we've been toying with the idea of whether you could be doing at least bipolars with a single assist. So that's an area to examine. And then of course, there's technology coming down the road, robotics, things that might get rid of the need for an X-ray, for instance, so there's no lead and no radiation for everybody. That's worth thinking about, but that's so far down the road that it's not really something that we're actively pursuing at the moment. That's it.